Good afternoon, everyone, and welcome to our weekly webinar on this last day of August. The heat wave has settled down, although I hear it's coming back soon. So you are in the coolest place you possibly can be today with us for our webinar, and so happy to see such a great turnout today, and your enthusiasm about today's topic is really inspiring. We'll get to that in just a moment. As always, please make sure you mute yourself while our speaker is sharing, and feel free to drop any questions or comments in the chat, and I'll watch that as Dr. Swerdlow speaks. We are recording, so you'll be able to watch this after today, and let's share it with anyone else you think might benefit, and we'll post that online as soon as we can. If you need closed captioning, bottom of your screen, you can click on the Show Captions button, and those will appear for you. I'll remind you that we have 3 showings of Why coming up. One is a week from tonight in Pittsburgh, Kansas. The next one is a week from tomorrow in Wichita. And the third one is on the 18th of September in Manhattan, Kansas. So if you're near to any of those locations and you haven't seen Why, I encourage you to do that. It's a great film. With that being said, we have a great webinar today. It is my absolute honor to welcome back Dr. Russell Swerdlow, who is the director of the Alzheimer's Disease Research Center and a professor of neurology, cell biology and anatomy, biochemistry, and molecular biology, and does work with brain energy metabolism and has done that for more than 25 years. So when we titled today's session, Ask the Expert, we really meant it. So with that being said, Dr. Swerdlow, welcome. Thank you so much for sharing your time with all of us today. I will tell everybody one other thing. We received some really great questions, and we could probably have webinars for the rest of the year with all of your thoughts for Dr. Swerdlow. We will get to as many as we possibly can, up to Dr. Swerdlow to handle that. So I will turn it over to you, Dr. Swerdlow. And again, thank you so much for sharing your thoughts today.
Well, thank you very much, Kelly, and thank you for everyone who's out there listening. Thanks for sending in what so far are about a dozen questions. In a moment I'll just jump into those questions. It really is a pleasure to get these questions. Part of it is, these questions help me think, and so I learn from it. And it's nice to be able to give something back, some information. So, because some of these questions are kind of very specific in their scope, and some of them are more general. But let's get to it. So, to paraphrase the first question, it's from someone who has an ApoE4 gene allele, and this person goes on to say that there's a family history of Alzheimer's, maybe a combination of Alzheimer's with Lewy body dementia, and the person wants to know, are there any lifestyle things that can be done to maybe reduce the risk of Alzheimer's? So to answer that question, just to give some more perspective to everyone, is that there's a gene called the ApoE gene. Everyone has 2 copies of it. One copy comes from your mom and one copy comes from your dad. And genes come in flavors, right? So it's what controls whether people have, let's say, dark hair versus blonde hair, or blue eyes versus brown eyes. These variations in genes. And this ApoE gene comes in different flavors. And one of the ApoE flavors that's out there is called the ApoE4 flavor of the ApoE gene. And about 1 out of every 4 or 5 people here in the United States has a copy of that ApoE. One of their ApoEs is an ApoE4. Now, people who have an ApoE4 have a higher lifetime risk of developing Alzheimer's disease. It's important to note that it doesn't mean that they're going to develop Alzheimer's disease, at any point in their life. A lot of people with Alzheimer's don't have an ApoE4, and there are a lot of people with an ApoE4 who will never develop Alzheimer's. But those who do are those who are born with an ApoE4 do have a higher lifetime risk of developing Alzheimer's. To what extent is that? So, to give you some basic statistics, the risk of getting Alzheimer's disease just by being born is relatively high. The risk of getting Alzheimer's disease just by being born is about 15%. So 15% of everyone that's born will end up with Alzheimer's. Um, if you have an affected parent, your lifetime risk goes up. It goes up to about 25 to 30% lifetime risk. Um, if you have one copy of the ApoE4 gene, meaning that one copy is an ApoE4 and the other copy is not, then your risk of Alzheimer's disease is also about 25 to 30%. So the risk of having Alzheimer's disease in those who have an ApoE4 is about the same as having a parent who's affected. So in this case, someone who has a parent with who had Alzheimer's, having the ApoE4 doesn't really change their risk quote. The risk quote is still about 30% lifetime risk because their parent had it. So you might think that, well, okay, maybe the parent that had it, maybe that's where they got their ApoE4 from. But that's kind of that being said, if people who do things like 23andMe and the test that comes back saying that, oh, you have a higher risk of Alzheimer's, that's largely being based on that 23andMe test revealing that someone has an ApoE4. So that's now one question that comes up is, just like, can anyone lower their Alzheimer's risk? Maybe people with an ApoE4 might want to be even more adamant about reducing their lifetime risk, doing the right things. And it sounds like this person has been, learning things from these meetings. It sounds like this person is, following a healthy diet and getting exercise. And, the person wonders, maybe if they can sleep better, would that help? Yeah, but these are all the things that we typically recommend as part of our LEAP curriculum, about trying to reduce one's Alzheimer's risk. So I would just say to this person that sounds like you're doing all the right things. There's some things that we're not sure about. In other words, the data don't really address the question one way or the other. But there are some people who are investigators who are looking into the possibility that maybe maybe fish oil supplements might be useful in people who have an ApoE4. It's not proven or disproven, but it's something that investigators are looking into. The other part that's relevant to this question is the person said that there was a relative who had Alzheimer's, and also on an autopsy, I think, was found to have Lewy bodies, which is something that sometimes leads us to diagnose Lewy body dementia. And I guess the point I would make about that is that Alzheimer's disease is often not a very clean event. We see changes in the brains of people with Alzheimer's disease that we see in other conditions of the brain, like Lewy body dementia. So people who have Lewy body dementia can have plaques and tangles, and people who have plaques and tangles can have Lewy bodies. That's probably it's probably more common than having a pure case. And typically, we kind of weigh the amounts of the pathologies. If someone has a lot of plaques and tangles and a few Lewy bodies, we'll usually just say it's Alzheimer's. If someone has a lot of Lewy bodies and a few plaques and tangles, we may say, oh, yeah, this is more consistent with Lewy bodies. So, um, but, but again, most cases of dementia are mixed dementias, where if you look hard enough, you see multiple different types of changes in the brain. Okay. So there's a question I think that came from the same person. The question is there a way to know what stage a person is in? And there are some basic you know guidelines that we follow to help us stage people. I'll tell you how I kind of stage them. So one is how active are people in the community? So for people that they have a dementia syndrome, so they and many of those people will be will be diagnosing the dementia syndrome as being due to Alzheimer's. And people with a dementia syndrome who are still going out into the community on their own. In other words, there's still some independent function in the community. Maybe they're going down to McDonald's to get lunch, or maybe they're still going out by themselves. They're still going out by themselves to go get their hair or nails done. Maybe they're going out to visit friends on their own. That's still independent function in the community. So typically that's kind of steering me in the direction of mild. Okay, so the big there's lots of ways to divide up to stage things, but the most straightforward and simple one is just mild, moderate, and severe. So so people who are are doing independent function in the community are usually going to be staged as mild. At least when that's what's going through my mind. When people are no longer doing things independently on their own in the community. Okay, so maybe that's no longer happening, but people are still going out into the community, with a spouse, and they're having fun doing things, out in the community. They may not be doing them on their own, but they're going out and doing things independently. Um, that kind of suggests moderate. So they're not. It's no longer so mild that they're doing independent activities in the community, but if things aren't so profound that there's that they're not going out anymore. They're still going out, just with with some support. And then when things get to a point where people are really no longer doing things in the community, that kind of corresponds to severe. If that hopefully that makes sense. And we can kind of see correlations with this on the exam. Now, when I see people in the clinic, I do one of my one of part of my exam is to do something called a mini mental state exam, or the MMSE. It's a 30-point test, and a perfect score, getting everything right, is 30 out of 30 points. And roughly, a score of about 20 to 30 would correspond to mild. Scores between 10 and 20 are roughly typically corresponding to moderate, and scores of less than 10 are usually corresponding with severe. So that's one very basic, simple staging system, the mild, moderate, and severe system, and hopefully that gives you some insight as to how we assign someone. Um, okay, so moving on to more questions. There's a question here. Oh, there's a follow-up question in staging. What signs signify going from MCI to mild Alzheimer's? Yeah, so the mi mild cognitive impairment is everything that the person does that they can still do independently. But if people reach a point where there are things that they used to do independently, but they can't do them independently anymore, then that goes beyond the mild cognitive impairment stage and into the mild dementia or mild Alzheimer's stage. So I guess by example, let's say let's say that I can still I was let's say I had some memory problems and I was diagnosed with mild cognitive impairment, but I was able to, everything was tougher for me to do, but I can still do everything I needed to do completely on my own. That might be mild cognitive impairment. But let's say as things progressed, I got to a point where I was still able to go to the supermarket and do my shopping, and I was still able to go out and get a haircut or still go out and visit friends and but maybe what I was having trouble doing, maybe I can no longer set up my automatic bill pay or you know, maybe I was missing my doctor's appointments because I simply couldn't remember my doctor's appointments. Um, or maybe I decided that if I was driving outside of my neighborhood, you know, um, I didn't want to do that anymore because I was scared I was going to get lost. That then it kind of goes beyond mild cognitive impairment, and it's affecting my activities of daily living. So that's dementia. So hopefully that answers that. That gives you the whole spectrum there, from mild cognitive impairment to mild dementia to moderate dementia to severe dementia. Okay. So then there's a question, what is the role of genetics and family history in one's risk or odds of getting dementia? And I think I kind of discussed that to some point earlier on. So genetics does influence Alzheimer's risk. There are these very, very rare cases of Alzheimer's disease where the Alzheimer's is flat out inherited um, due to a mutation in a gene. We can usually detect those purely genetic versions of Alzheimer's disease through a family history. Those are family histories in which we see the disease moving from generation to generation to generation, getting about 50% of everyone within a generation. And typically the onset is at a very young age, typically in the 40s, maybe the early 50s. So, when am I thinking about this kind of genetic Alzheimer's? I'm thinking about it, let's say, in someone where I'm diagnosing Alzheimer's and they're 50 years old, and I find out that their father had Alzheimer's disease and developed it around the age of 50, and the father's mother developed it around the age of 50. And that's the lightning is striking too many times too early. And so think about a reason why that's happening. And in those cases, we'll check for mutations in the genes that cause early onset familial Alzheimer's. Less than 1% of all the cases of Alzheimer's are due to that. Um, I've at this point, I've been an Alzheimer's subspecialist for closing in on 30 years, and I found about maybe half a dozen, maybe a few more than half a dozen cases of these mutation Alzheimer's disease of the thousands of people that I've seen. So what's more relevant is the genes tweaking your lifetime risk, like the ApoE gene that I spoke about. There are now about another 40 or 50 genes that are known to affect the Alzheimer's risk. All of them have a really, really, really tiny effect. Um, you know, investigators like myself, we spend a lot of time trying to add up those little tiny risks and see if we can get a bigger risk by adding up one sum total of risk from all the genes that we know about. But even if we add up all those genes, it's just this little tiny bit of risk. And the ApoE gene is a much bigger risk, but even the ApoE gene does not will not tell you whether you will or will not get Alzheimer's. So another question, where can a person get tested for genetic likelihood of Alzheimer's disease? That, you know, the most clear way to get that done in this day and age, that where it's where maybe it's, you're not just, you know throwing a dart at a little tiny target, would be the ApoE gene test. So the ApoE gene test will sometimes be tested for by doctors for various reasons. Sometimes it's tested as part of a workup to determine someone's cardiovascular risk status. Um, in the neurology world, in the memory disorders clinic world, in the memory clinic world, we we generally don't recommend getting it tested, but sometimes people really, really want to know. Um, and yeah, and we'll do it. It costs a couple of $100 to get it done, although it can be done more cheaply if you just do it directly through 23andMe if you wanted to do that. I would just say I have had people who've come to see me in clinic because they ended up having their ApoE status determined for whatever reason, and they found out that they had an ApoE4 and they heard it was a risk factor for Alzheimer's, and then they come and see me, and they're doing fine. And I kind of tell them that, you're like one of every four people in this country who has at least one copy of the ApoE4 gene, and we can keep an eye on you, but I don't think we need to do anything more than that. So, and it's a very personal decision on whether people want to know or not. Some people are very high information, and some people, would rather not know. Um, One of my colleagues, who sees patients in the memory clinic, is a very high information person. And wanted to know, and had it determined. Whereas I'm perfectly happy not knowing. Okay, so could you describe the difference between early onset Alzheimer's disease and the more typical Alzheimer's disease people age 65 and older get? So there's the main difference between these two Alzheimer's, and I've touched upon this a little bit, is the age of onset and the familial pattern. So the familial forms tend to hit at younger ages, people in their 40s and their 50s, although I've had someone in their 60s who's had one of these mutations. And but they usually present earlier. So, a lot of times I'll see an 80-year-old in the clinic who will say, I've diagnosed with Alzheimer's, and they'll say, I had a parent who had Alzheimer's. And I'll ask, when did your parent get Alzheimer's? And they'll say in their 80s. And that's not going to be this this pure genetic form of Alzheimer's. That's going to be, it's a common process in older people, and in an older person who had a relative who got it in old age. That doesn't necessarily mean it's familial. Um, but in some ways, what we see in the clinic is otherwise similar, which is people develop problems with things like memory and language and other skills, and it becomes more noticeable over time. So, um, it's different ways to get a clinical condition that kind of looks, in some ways things behave very similar, but the ages are different. Okay. Why are we seeing more people diagnosed with dementia now than we did a generation ago? There are a number of reasons. One is that people are living longer, and older age is the greatest risk factor for for developing Alzheimer's. Another is uh, is that we're we're better at making the diagnosis, I think. We're willing to make the diagnosis at earlier stages of cognitive decline. We have tests that can help with that. Um, and and people are more likely to go see a doctor now, I think, if their memory is not that good. It used to be, I think, decades ago, if someone was in their 80s and their memory was failing, the thought was, oh yeah, they're in their 80s. That's kind of natural. And now people are feeling pretty good in their 80s, right? So if their memory's starting to fail, rather than just say, oh, I'm just getting older, they'll go talk to a doctor about it, and then that might lead to a diagnosis. And then the final reason why I think it's more common now, or more commonly diagnosed now, is that you know, we there's been a push within the field to liberalize the definition to to make it um, to make it easier to diagnose people in some ways. In other words, if someone has, let's say, plaques and tangles in the brain, even if their memory isn't that bad, uh, some people would say, yeah, let's go ahead and call that Alzheimer's disease. So for all those reasons, I think it's diagnosed more than it used to be. Um, Next question is, why are there more women with Alzheimer's disease than men? And that's that's a question that a lot of people are studying. There are some reasons that are probably account for that. One is that women tend to live longer than men. So, and since age is the greatest risk factor for Alzheimer's, the fact that women live longer increases their lifetime risk of developing Alzheimer's. But it's not just that. If you look at even at younger age groups, like in people in their 70s, which is an age where the men really haven't started dying off yet, you still see higher rates in women. And so there's something about that maybe make women a little more susceptible to this. And it's this a lot of investigators are trying to study this sex difference to try and get clues into what drives Alzheimer's disease and how we can treat it better. Next question. What are the benefits of participating in the TDAD study? Okay, so the TDAD study, um, TDAD is a study that's looking at how the foods we eat may influence how our memory performs in people with mild cognitive impairment or Alzheimer's disease. So in this study, you the person participating in the study meets with a nutritionist, and we give specific advice on foods to eat, and then we and that person will eat those recommended foods for 3 months, and we'll track them to see if it's helping their memory or not. And so what we're trying to learn from this study is, can we affect our memory or improve our memory based on what we eat? And the goal of this study is really not even to just slow down decline. The purpose of the study is to actually see if we can get people to improve their memory by by um, by having them eat certain foods. So that's the purpose of the TDAD study. And one potential benefit is if we find that certain foods end up improving memory, then that's obviously a benefit. Um, and certainly those who participate in the study will learn a lot about nutrition. And so it's it's kind of, I think a lot of people have had a lot of fun doing it. It's certainly been a delightful study to be able to perform here. Okay. Here's a question that I actually had to look up. What is the relationship between dementia and blood type, and especially type AB blood? And what I can say quickly about that is there were some studies about, close to 10 years ago in which some investigators said it looks like people who have the AB blood type have a higher lifetime risk of developing Alzheimer's, uh, which was followed up by other studies that said, "Hey, yeah, we looked at this and we don't see that." So the so it falls into some studies say yes and some studies say no. The studies say yes, they're just sort of guessing about if there is an increased risk, what might that be due to? And they're thinking it might have something to do with inflammation. And what I would say is that, boy, so this the this was a big story, I think, about 10 years ago, and we're not hearing much about we're hearing less about that story now. So my guess is that if blood types do influence Alzheimer's risk, it's probably a pretty small effect, and it's not something where I would lose any sleep over. Um, and so based on that, that goes to the next question. If someone has a higher risk blood type, is there anything that they would do to change their Alzheimer's risk? And I would say, yeah, my guess is that if there is an impact of blood types on Alzheimer's risk, it's probably so small that I wouldn't lose any sleep over it. And I'm not aware of any treatment trials that are looking at this topic. So Kelly, I don't know. Are we supposed to wrap up at 2:30 or 2:45?
30 is about
Okay.
our time, although I think I can speak for everyone that we would hang on every word you say, Dr. Swerdlow, for much longer. But I think that means we'll have to ask you to come back to another webinar another time.
Okay.
Um,
Well, it looks like there's some questions here.
sure.
Um,
Yeah, there are a
so
couple in the chat if you don't mind.
okay, so let me see. Yeah, I can just click. So I answered the staging question. If time, what is the status of the newer blood test to diagnose? Oh yeah. So there's a lot of work on blood tests that will give us it's that we use to diagnose Alzheimer's, but to put a little perspective on it, the test technically is really, I don't think of it as diagnosing Alzheimer's as being present or not. What the tests are really, these blood tests are trying to do is trying to tell us if someone has plaques or not. So, yeah, we're getting better at being able to look at the blood and measure things in the blood, and what we see in the blood can give us some refinement as to whether someone is likely to be having plaques and maybe tangles in their brain. Um, these tests are not perfect. There's a lot of overlap, so they don't predict perfectly. But you if you look at 100 people, with who have plaques and 100 people who don't have plaques, and you look at the mean, the average on the blood test, the averages will be different between the two groups. But this might one day, the hope is that a test like this might be able to tell us information that we commonly get now by typically doing a spinal tap or doing an amyloid scan to look for plaques. But they're not quite right. We're starting to do these in a research capacity in the clinic, and we're certainly doing it in a research capacity in the Alzheimer's Center cohort, but they're not quite ready for pure clinical prime time just yet. Let me see. Are we using Alzheimer generically without any dementia? I think that what that question is referring to is, would we diagnose someone with Alzheimer's who has either mild cognitive impairment or who is fully normal in terms of their cognition, but has plaques and tangles? And the answer is, in the research world, we have specific terms for that. In the research world, if someone has normal memory and plaques and tangles in their brain, we will call that preclinical Alzheimer's. If someone has plaques and tangles in their brain and mild cognitive impairment, In the research setting, we will call that prodromal Alzheimer's. So, so we have these terms that we will apply, but in the clinic, uh, I generally reserve a formal Alzheimer's diagnosis for people who have dementia. Okay, because I believe that really what we're trying to diagnose and manage is the clinical problem, not diagnose and manage the biomarker or the plaques. Okay. Does the CPAP or BiPAP impact dementia? Some people believe it does. Um, some people believe that if if you have sleep apnea, that you have a memory problem, that maybe CPAP or BiPAP might be something worth trying just to see if that helps. If it ends up helping with your sleep, maybe your memory is going to be better the next day. So that's um, that's that question. And where do I find the info on my 23andMe reports? I, I don't know for sure. There must be a way to look at it under risk of dementia or risk of Alzheimer's. I've never done 23andMe, so I don't know exactly what the reports look like. Oh, is there any evidence that lion's mane mushroom supplements from a reputable source may help prevent dementia and Alzheimer's? Well, that falls into the stage of, there's not really any convincing data that confident data that it either that it helps or it doesn't help. There are some studies, where people are saying, yeah, maybe this will help, and maybe this will lead to other studies, and maybe we'll get a pure answer from that. But the answer is, we, you know, we, the data just there aren't there to tell us definitively one way or another. I tend to be pretty conservative about these things. Yeah, until something's really been shown to be a benefit, I'm thinking I'll spend my money on other stuff. Okay, let me see. Okay, well, I guess that's the end. So
That
thank you
is,
very much.
yes, I hate to tear us away. Thank you so much, Dr. Swerdlow, for your very kind and thoughtful answers. And I have to say, I love that you said you had to look up the one about the blood types, because I think that speaks to our willingness to learn and grow. And that's always what we want to promote on the webinar. So thank you for helping us to learn. I know I took some furious notes today, and we'll be happy to share information with uh, anybody as you contact us through My Alliance. Next week's speakers will be Deborah Schaus and Ron Zoglin, who are caregiving experts and book writers and storytellers and lovely people. And they will be sharing about their adventures, including perhaps some conversation about the new Kansas City airport and how it is, they're working on making it to be dementia friendly. So stay tuned for that. We have a lot of great speakers coming up over the next several weeks. We're very excited to do that. And Dr. Swerdlow, I think you've got a lot of kudos in the chat, so make sure you take a
Yeah,
look at
thanks
those.
everyone for your nice comments. Thanks for your attention. See you guys
And
next time.
yeah, so we'll see you all next week. Have a great one. It'll be September when we meet again. Take care, everyone. Bye bye.